Started your timer and here is your question. Right, so if you have read and understood considering HST technique station, can we begin? Dr. Mohammed, time begin please. Dr. Mohammed, are you there? So here is your timer, you can begin now. If you have read
Hello.
and understood, yes.
I'm Dr. Muhammad, one of the exam legal candidate. Today I have been asked to ask you some questions related to your condition. Are you okay with that?
Yeah, please.
Thank you. May I confirm your name and age, please?
Yeah, my name is John and I'm 43-year-old.
43 years old. Okay, nice to meet you, Mr. John. So what's brought you here today?
Doctor, I'm having this pain in both of my legs for some time now.
I'm really so sorry to hear that. When did you first notice that?
Actually, I first noticed a few months ago. It was not that much, but now it's increasing.
I'm sorry to hear that. Can you point the site of the pain, please?
Could you ask that again?
Can you point to the site of the pain, please?
Point it at the side.
Yeah,
of the pain.
so the pain is actually in both of my legs, basically on back side.
I'm sorry to hear that.
Yeah.
Did it start suddenly or gradually?
It started gradually, actually. Slowly, it increased.
Okay, can you describe the pain for me? It is cramping or cold in nature?
No, it's more of cramping.
Okay. Does it change throughout the day? Does it go and come?
It's not related to time of the day, actually. It's more on walking.
More on walking. Okay. Is there anything which makes the pain increase or stop?
Yeah, it increases while I walk a few meters, and it will get relief when I take rest.
Okay, I'm sorry to hear that. If you would rate the pain from 1 to 10, 10 is the worst imaginable, how would you rate it?
It's probably around 7.
7. Oh, really sorry to hear that. Do you want me to give you any kind of analgesic?
No, I'm fine right now.
Okay. How does it affect your day-to-day life?
It's actually quite worrisome because I'm not able to walk around much and not able to carry out daily chores. So I'm quite worried about that, as I'm not able to carry out my works as I used to previously.
I'm sorry to hear that. So it is relieved by rest?
Yeah, it is relieved by rest. And also, as you asked, a few months ago in the winters, the pain actually increased. It was more severe. But now with the summers, it has decreased a little bit.
So it is related to the cold weather. Okay.
Yeah, also
does
cold
it,
weather. Yeah.
Yes. Does it increase by walking up hills or walking faster?
Yes, it do increases.
Okay. Did you notice that there is any skin breach in your skin?
Skin what?
Breach or
Breach.
any kind of ulcer?
No, nothing like that. Everything is fine.
Okay. How far you walk before you can stop?
It's around 50 meters.
50 meters. Okay. Do you have any back pain?
Yeah, I have back pain too.
Does it radiate to your buttocks or legs?
I think so. Yes. First, back pain was there, and now I'm feeling this leg pain in both of my limbs. Actually,
Okay.
it's going
Do you
down.
have any numbness or leg weakness?
No.
Okay. Do you feel that your back pain is increased when you're walking uphill or downhill
It
or
actually
leaning
increases
forward?
while walking. By
Okay.
leaning forward, it decreases, but walking uphill, it increases.
Okay. Do you often see your GP for any other medical conditions?
No. This is the only
Okay.
problem I'm having.
Have you underwent any surgery before?
No.
Okay. Do you take any long-term medication or allergic to any other drug?
No, I don't.
Okay. Is there any family member who has the same condition?
No, I'm the only one.
Okay. Before I go further, can I ask some personal question, please?
Yeah, please.
What's your occupation?
Actually, I'm a teacher.
Who is at home with you?
My wife and my 2 kids.
Okay. Do you smoke or drink alcohol?
I don't drink, but yes, I do smoke. I've been smoking for the last 15 years.
15 years. How many packs per day?
Approximately 2 packs these days.
Okay. Do you have any difficulties with the stairs?
Difficulty of what?
With the stairs?
Oh, yes. Yeah, because of this pain, I'm having difficulty in walking uphill, and the stairs also. Stair climbing is difficult.
I'm sorry for that. So what do you think is the cause?
Can you summarize
I
your
really
history
don't
now?
know.
Okay, thank
Thank you.
Yes. You're disconnected again?
about systemic reviews.
Yes.
Presented with pain in his calf for a few months ago. Started gradually, increased by walking and relieved by rest. And also he is a smoker and has for 15 years ago with 2 packs per day, and also he has back pain radiated to the buttocks and lower limb.
So what are your differential diagnoses for this patient?
My first provisions could be chronic limb ischemia,
Yes.
or it can be due to intervertebrative prolapse or sciatica.
Okay. What other differentials would you consider?
It can be due to spinal stenosis
Yes.
or disc prolapse.
Okay. All right. Can you please tell me how would you manage this patient? What investigations would you ask for?
After taking history, I will examine the patient firstly, neurological examination and cardiovascular and vascular assessment. After that, I will ask for about doublet ultrasound and CT angiogram or MRI angiogram.
All right. Can you please tell me how would you differentiate if the pain, the cause was vascular claudication or the spinal claudication?
Okay, for the vascular, it is relieved by rest and it is cramping in nature.
Yes.
For spinal stenosis, there is usually back pain which radiated to the lower leg, and it is increased when patients walking down stairs.
Okay. Any other difference?
Uh,
What are the treatment options that you can offer to this patient?
Treatment first, I will conservative and control the blood pressure and cholesterol level, and also stop smoking.
Yes.
Then I will prescribe for like aspirin and clopidogrel, and also some anti-cholesterol lowering like simvastatin.
Okay, if conservative management or medical management fails, what can you offer to the patient?
Then patient might need surgically, like endoscopy, or implantomy or amputation.
Yeah, and the vascular stenting or yeah. Okay. How would you differentiate if it is sciatica pain?
Sciatica is a shooting pain,
Yes.
which associated with numbness in the legs or buttocks.
And there is a history of lower back pain.
Lower back pain, yes.
Yes. Okay. Good. Thank you.
Thank you.
About the difference between peripheral and vascular, you just told me one. If you can tell me any more. One difference is that it is brought about by exercise and relieved by rest. That is one, if it is peripheral vascular disease. Then it is exacerbated by the walking faster or by going up hills, and also by cold weather. Cold weather, yes. And the risk factors are the ones like diabetes, hypercholesterolemia, atherosclerosis.
Yes, associated with risk factor.
Pain, yes, can indicated by the critical limb ischemia. Whereas the spinal only, relieved by walking uphill, and there are associated limb numbness.
Okay.
Good. Okay. Yes. Can you give feedback first? What did you miss? Because we had a gap, so you didn't tell me. If time would have allowed you, you would have covered your history.
I said that.
Okay, sorry, my network, I can't hear you.
Okay.
All right, yes. Can anyone else give feedback? Dr. Prabhajit, how did you find it? Anything you can improve, can do better?
Yeah, I think he has done quite good.
Yes.
And just the last few things, the expectations of the patient, all these things. If the time would have allowed, I think he must have done that too.
Yes.
Yeah, it was all fine.
Good. Thank you. Your question. Right. So if you have read and understood, considering the critical care scenario, kindly tell me how would you manage this patient now? What would be your next step?
So considering this as a critical patient, so I'll go with CRISP protocol. Yes. Firstly, I'll manage the airway and breathing, circulate according to the protocol.
Yes.
And as the patient has a BP fallen down, so in this case, I will go with the fluid resuscitation. And as this is a pregnant lady, left lateral position can be done. Patient can be brought to a supine position from reverse gentle birth. Then if the BP does not improve with the fluids, then I can go with the inotropes and the vasopressor agents in order to increase the blood pressure.
Right. In what type of shock do you think patient is right now?
It's basically cardiogenic shock is the most probable diagnosis due to decreased preload.
Preload. Okay. Can you define the term preload, please?
Preload is defined as the of blood in the ventricles at the end diastole.
Okay. So there is a preload and diastolic volume is affected by, or it affects.
So
Can you
it
explain
affects the cardiac
yes,
output.
cardiac output,
Yeah.
yes, and the venous return.
Yes.
All right. Can you tell me, Can you tell me what is the mechanism behind the preload or the venous return? How it occurs? How it takes place? The physiology behind it?
So basically, preload is the blood volume which is circulating, is the venous return to the heart, and it affects the muscular contractility according to the Frank-Starling law.
Very good.
Which
What
defines
yes.
as, Frank-Starling law in cardiac or heart is the amount of stretching or the pumping of the blood through the heart is directly proportional to the amount of the blood that is present in the ventricles, which stretches the muscles up to a point.
Okay, all right.
So
okay,
more
yes.
the venous return is there, so
Yes.
more will be the cardiac contractility and the cardiac output, which will further systemic vascular resistance.
How this venous return will decrease the venous compliance?
So venous compliance, veins are very compliant vessels. So this can be decreased with the sympathetic discharge.
Yes.
So sympathetic activity contracts the veins and increases the venous compliance, which leads to increased preload and the cardiac output and further pressure.
And increases what? Which promotes increase in venous return indirectly? Central venous pressure. Okay.
Yeah,
Can you
absolutely.
please tell me why in this patient there is decrease in blood pressure? What has happened?
So first the patient pregnant, so compression of the inferior vena cava by the uterus.
Yes.
As the patient is pregnant lady, that is one cause. Second, it could
What
be
has
the
it
reverse
done?
central
Please
position.
complete your sentence. Compression.
It has compressed the inferior vena cava, leading to
Then?
decreased preload and cardiac output.
And as a result, decreasing
blood
the venous
pressure is
return.
directly decreasing.
The venous return
the
and
venous
the cardiac
return.
output. Good.
Yes.
Yes. Okay. Can you Can you tell me what are the measures that you can take to prevent this happening?
So for the prevention, the laparoscopic surgery could be converted to open surgery.
All right.
Because
what would be the benefits of doing it as an open surgery, open laparoscopic?
So in laparoscopy, we use carbon dioxide in order
Yes.
to dilate the abdominal cavity, which further compresses the vena cava and decreases the preload and cardiac output. So open surgery won't involve all this. So that'll be a better thing to do. And,
how would it affect the fetus? Or the
so
respiration of the fetus?
Necrotic cholecystitis, all this sepsis will be removed. So sepsis will be removed from that, and
Yes.
they'll be decreased. There'll be the preload will be more. So the cardiac output of the maternal side will be more, which will lead to increased fetal circulation.
What are the risk
beneficial
factors that you have to keep in your mind while doing this procedure on this pregnant lady?
So the first risk factor is it could lead to early labor and delivery of the fetus.
Or
intrauterine death, fetal death could occur. And maternal complications.
Long-term duration can lead to DVT.
Yes, DVT. Yes.
Or anything else that you can tell me how it can affect. They could lead to trocar injury to uterus, because uterus, it becomes huge and you're operating. So that's one risk factor you have to keep in your mind. It can also decrease the blood flow to the uterus. It can also lead to fetal acidosis. It can also causes decreased visualization due to grave uterus. So that's one mechanical because of Yeah, huge thing. So what would you prefer?
Yeah.
Would you prefer to induce premature premature delivery in the lady first, or would you go for the lap chole first, laparoscopic cholecystectomy?
I think lap chole should be done first because it's a necrotic gangrenous cholecystitis.
Yes.
So that is an emergency to be done first.
What are the healthcare professionals that whom you will involve in this case?
So a pediatrician,
Yes.
obstetrician,
Yes.
ITU registrar, anesthetist.
Yes.
Yeah, these
And-
4 people are important.
Okay, and general surgeon, you yourself. Right. Can you tell me where are you going to monitor this patient?
In obstetric HDU.
Right. If you suspect that there is a risk of DVT or deep vein thrombosis in this patient, what are the prophylactic measures that you can take in order to prevent that from happening?
So the pneumatic compression devices, intermittent pneumatic compression devices can be given, which are the mechanical, TEDs
The
or the
most
thromboembolic.
common, begin with
stocking.
the most common one. Yes, from stocking to, yes.
So so the most common, the most important thing is post-operative early mobilization of the patient
Yes.
and decrease the surgical time.
Yes.
Then these mechanical measures, which I just mentioned,
Yes.
and then blood thinners like low molecular weight
Patient is
heparin.
pregnant. Think which one is suitable for a lady who is pregnant now and will be breastfeeding afterwards. So which blood thinner
So
can you recommend, or
mechanical,
anticoagulant can you recommend?
I think heparin, low molecular weight heparin. I'm not sure.
Okay, we'll come back to this one later. Can you please explain the mode of action of the stocking that we recommend in order as a prophylactic measure
So
for DVT?
the stocking,
Yes.
yeah. So stockings are graduated and they are custom for each patient. They have
Yes.
graduated compression from distal to proximal. So it leads to pumping action of with the pumping action of the muscles that leads to increased blood flow or the
effect.
circulation.
Yes. Not
milking
pumping,
effect.
milking. Okay, that improves the venous return. Then what happens?
So basically the blood in
Blood
the
pooling.
superficial veins.
Yes.
Blood pooling does
or
not occur.
blood
So
stations. Yes, good.
deep vein thrombosis does not occur.
Or a bell has gone, but then I want to make sure that you know this inside out, this topic. So can you please tell me what would be your ideal inotropic to ask for this patient, or to suggest for this patient?
So I think the inotrope dobutamine will be the best because it will decrease the systemic vascular resistance also, along with increasing cardiac output, which will increase the blood pressure. Because if systemic vascular resistance is increased, this will lead to decreased fetal blood flow, which will be harmful. So a dopaminergic inotrope will be the best, along with the fluid therapy.
Okay, as a result of decreased blood pressure in this patient, okay, from normal to decreased, what are the body reflexes or the body responses that will be activated?
So the first is the sympathetic system will be activated.
Yes.
Which leads to, there are two effects.
Is it sympathetic, which is the first, or the baroreceptor, which is the first?
The baroreceptors are the first to get activated. They are quickly
always
activated.
Mention the first one first. Yes, please.
Okay, so the baroreceptors are the mechanoreceptors which are present in the carotid sinus as well as arch of aorta, and they act according to the pressure dilatation of the walls of the arteries. So reflexly, they decrease the systemic vascular resistance, but increase the cardiac output with the sympathetic discharge of nerve of hearing, which is the glossopharyngeal, the nerve 9. It increases the cardiac output. It increases stroke volume. and decreases increases peripheral vascular resistance. So in whole, the cardiac output is increased, leading to increase in blood pressure. So these are the one. The next is a sympathetic system,
then
where
hormones.
the hormones, including the RAS system, renin-angiotensin system, due to decrease circulating blood.
Yes.
It is
Any
activated,
other hormone?
leading to release of renin and aldosterone.
Any other hormone?
Catecholamines through the adrenomedulla, also directly.
Oh, cortisol, etc.
Yeah,
Okay.
catecholamines, cortisol, that's the catecholamine. So it increases the resistance. The renin system increases the water retention, which increases the blood pressure.
Good. Right. Yes. Nice. Good. And here is your question. Right. So if you have read and understood, considering it surgical anatomy station, kindly tell me, what are you looking at right now? What is this left picture?
Ma'am, this is the prosected image of the heart.
Yes.
So the structures it is showing the internal structures of the heart. That is, one is the tricuspid cusp of the tricuspid valve. Number 5 is the chordae tendineae, and number 2 is are the papillary muscles. Number 7 is the infundibulum of the right ventricle, and 9 is the pulmonary trunk.
All right. How many? Oh, all right. Okay. How many papillary muscles are there in the right ventricle?
In the right ventricle, there are 3 papillary muscles, ma'am, attaching to the each cusp of the tricuspid valve.
All right.
They prevent the collapse of the tricuspid valve.
Yes. If you can move on to the right-hand side picture, can you please identify what is this 3? Where is yes. This one? What is 3? Please. Can you identify?
And that is the ascending aorta. Hello.
Yes. Okay. Right. And then 5, please.
And that is the auricle of the right atrium.
Can you please identify 18, please?
And that is the right atrium of the heart.
Okay, 25 over here.
Superior vena cava draining into the right.
Very good, very good. 17.
That is the pulmonary trunk.
Yes, very good. If you can identify, it's 22, I guess, over here.
That is the right ventricle forming the anterior border of the heart.
All right. Can you please tell me the development of the heart?
Yes, ma'am. The heart is formed by the joining of 2 endothelial tubes forming primitive heart tube.
Yes.
So it is divided from proximally to distal by truncus arteriosus, bulbus cordis, primitive atrium, and the sinus venosus. The bulbus cordis and the primitive ventricle forms the ventricle, and the bulbus cordis and the truncus arteriosus forms the pulmonary trunk and the aorta, while the primitive atrium and the sinus venosus form the inferior and the superior vena cava, and the 4 pulmonary veins leading
Good.
into the
Can
atrium.
you please tell me the blood supply of the heart now?
The heart is supplied by the 2 branches of the ascending aorta, the left
Yes.
and the right coronary artery.
Yes.
The right coronary artery arises from the anterior aortic sinus, and the left coronary artery arises from the posterior aortic sinus.
Can you
The-
identify
yes.
which this vessel, where is my question? This vessel belongs to which vessel?
And
Or
that is
it's
the
a
left
branch of-
anterior branch coronary artery.
Left coronary artery. Okay. This what is the territory of supply of this vessel?
The anterior descending artery supplies the anterior interventricular septum and also
Yes.
the anterior portion of the right and left ventricle and the
All
apex
right.
of it.
All right. Can you tell me what is the variation? It can sometimes present within variation.
Yes, and sometimes it can be a tributary of the branch of the right coronary artery.
Can you please tell me? Yes. Can you please tell me what is coronary sinus?
Coronary sinus is the sinus situated in the posterior atrioventricular groove where coronary veins, the cardiac veins drain the venous blood from the heart.
All right. Okay. Can you tell me pulmonary valve has how many cusps? And what is the surface marking of it?
The pulmonary valve has 3 cusps,
Yes.
and the surface marking of the pulmonary valve, the second intercostal space in left parasternal area.
On the left side.
Yes.
Yes. Okay. Can you please identify structures from A to G?
Yes. Number A is the ascending aorta.
Yes.
Number B is the auricle of the right atrium.
Yes.
Number C, the structure C is the pectinate muscles of the ventricle.
Yes.
Structure D is the tricuspid wall. H are the papillary muscles in the
Yes.
right ventricle. Structure G is the left anterior descending artery. Structure E is the pulmonary trunk again, and F is the auricle of the left atrium.
Very good. Okay. Can you please tell me what is the, all right, can you please tell me the SA node is supplied by what?
That is supplied by
which?
the, in terms of blood supply,
Yes.
it is supplied by the right coronary artery in 2/3 of the people, and in 1/3 of the population, it is supplied by the left coronary.
Yes. And in 3% it's 2. All right. Can you tell me, right, what are the tributaries or what are the tributaries which drain in coronary sinus? Did you tell me before?
No, ma'am. The great cardiac vein, which accompanies the left anterior descending artery, the small cardiac vein, the oblique cardiac veins, and the middle cardiac veins drain into the coronary sinus.
All right. Okay. What about the right subcostal veins and the ascending lumbar veins? Where do they drain?
Can you please repeat the question? Your voice
The right subcostal veins and the ascending lumbar veins, where do they drain?
The right subcostal vein, the ascending lumbar vein form the azygous vein, and they drain into the superior.
Okay. Here, would you be able to identify azygous vein?
Yes, the structure 1 is the azygous vein, arch of
Can you
azygous
please
vein.
tell
Yes.
me what are the tributaries of azygous vein?
Yes, ma'am. The right superior intercostal artery, the pericardial vein, the esophageal veins.
Yes.
I think there is one. The mediastinal veins.
And pulmonary veins, you told bronchial, right and left bronchial veins, the right phrenic.
Yes, mediastinal.
Yes, and
Esophageal.
esophageal, yes. Thoracic outflow. Okay. All right. Good. Yes. Can you tell me the pathway of esophagus vein? All these tributaries and then esophagus vein goes from where to where? What happens with it?
Ma'am, it accompanies the abdominal aorta from the diaphragmatic opening,
Yes.
and then it into the superior vena after getting its supply from various tributaries.
Good. Thank you. Okay. Started your timer, and here is your question.
Hello.
Just a few seconds.
Hello, I'm Fozia, one of the surgical.
Just a few seconds left. Wait, please. There was joining sound. Somebody joined. Just 5, 4, 3. Yes, so if you have read and understood, considering the communication skills session, kindly begin.
Hello, I'm Fozia, one of the surgical residents, looking after Lily. Are you Lily's mom?
Yes, doctor. Yes. Yeah. Where's my daughter? Doctor, where's she? Is she fine, doctor? Like,
Yes.
where's she, doctor? Can I see her?
Yes, you can see her. But
Yeah. Where is she,
let's first
doctor?
discuss about her. Are you okay with? Would you like me to tell you about your doctor first, and then I'll
No,
accompany you to see
I
her?
want to see her first, doctor. No, I want to see her. Can I see her
Okay.
now?
Yes, you can see her anytime, but discuss regarding her health. Can I
What has
just
happened to her, doctor?
do you know anything about your daughter's health status or health condition? What were
No,
you
I was
told?
told like she was sick, like, and then she was brought to the hospital. Like, I'm really worried. What happened to her, doctor? Is she fine?
Yeah, she's fine. Basically, she had some complaints in the at her school, and she was brought here by her teacher. And we did some tests, and it seems that she has appendicitis, and
Appendicitis?
she has infection of an organ which is present in our tummy, and for that she needs an operation.
Operation.
She needs an
Oh
operation
my
for that.
God.
Would you like to have a glass of water or something?
No, doctor. I just want to see my daughter first, doctor. Can I see her now?
Yeah, I'll make sure that you will see her, your daughter at proper time. But I need to discuss you with. I need to discuss with you first what is going on, and what are we going to do. Make her because our first concern is your daughter's health, and later I'll accompany you to see your daughter. Is that okay with you?
Yeah, she told me she needs operation. Why, doctor?
She has infection of an organ which is known as appendix, which is present in our tummy, and she needs surgery for that, as I told you earlier. And we are waiting for
Are you
our
sure she
consult.
has appendicitis?
As per her complaints and as per our findings when we examined her and the test we have run, it seems that she has appendicitis, but we can't be sure 100% until we operate her.
Dangerous, doctor?
Usually it's a common condition in children. Children usually have appendicitis, and it's not usually that serious, But usually children have less fat in their tummy, so there is usually a risk of perforation. So that's a bad thing that will cause the infection to spread in the abdomen, and that will be dangerous. So that's why we are planning to get her operated as early we can.
So what could be the other problems, doctor?
uh, as the other problems are she needs to be operated under anesthesia. I think she is fit for that. I have shown her file to the anesthetist. Apart from that, if we don't operate her and the infection remains there, it might affect her tube on the right side, leading to subfertility later. Are
Oh
you
my
okay?
God. Does she mean that she will not get pregnant in future?
No, basically all females have two tubes. She has on the other side, and and hopefully she will do good. And there is a chance of subfertility, not being infertile.
Oh my God. So who is the surgeon? Who is the operating surgeon, doctor?
Mr. Ladd, our consultant, is.
Oh, Mr. Ladd. No. Mr. Ladd operated on my husband, doctor, and he succumbed. No, I don't want him to
I'm
operate on my
sorry. I'm sorry to hear
doctor.
about it. I'm sorry to hear about it.
No, doctor. No.
I'm sorry, but can you tell me when and how did this happen?
No, doctor. Yeah. No, it was a few years back. I think Mr. Ladd, I think he's the one. He's the same surgeon who operated on him, and then he died after 5 days he died. So I
But
don't want to get my daughter operated by him. No, doctor.
he's one of the excellent surgeons here. Could you tell me a bit more about why, for what condition your husband got operated by Mr. Ladd?
Yeah, they said he has cancer in his, in his colon or something, and then he was operated, and he couldn't survive.
These seem two different things for me, because I think your husband might have died of the cancer itself, because Mr. Ladd is one of the surgeons working in this hospital. You should reconsider it. You always have your right to choose your doctor, but Mr. Ladd is one of the best surgeons here.
No, I want to go for another surgeon.
Okay, let me see if I can talk to another consultant, but it might be time consuming because the next consultant has through the file and through the case, and there is a
Okay, please
chance.
This
get
you
me
are
another.
not going to do an exam. Yes.
Okay, doctor, you said you are going to operate on her. Okay, so
Mm,
so is she going to have a very big scar? She's a little,
it-
and then when she grows up, if she's going to have a scar, and then
Usually it leaves a small
harm her.
horizontal, small linear scar, but there are chances to that it might be that if we extend the scar or if it gets infected, it might be disfiguring.
Oh, um, this is really worrying, doctor. Already she is this thing, and then she's not fine. She needs operation, and the operating surgeon is the one, this Mr. Ladd. I'm really worried. I need to see her first, doctor. Can I see her?
Yeah. Do you have any other questions? And could I? Is it anything that you didn't understand or you want me to ask at present?
No, I am just worried. I want to see my daughter first, doctor.
Well, I can come as I told you earlier. I'll accompany you to see your daughter later. But do you have any questions, or could you summarize what I told you? Do you understand all of it? Did I?
Yeah, I think I understood what you tried to tell me, doctor.
Okay, thank you. I'll see, and I'll accompany you to see your daughter.
Okay, doctor, that would be nice. I want to see her first.
Good.
Thank you.
Thank you. Right. Can you give the feedback to Dr. Fulsman? Dr. Kama, can you give the feedback
yes.
first? Yes, please.
Dr. Fultz, thank you so much. Nice, you tried to
Her level best. Yes.
tackle, yes, her level best to tackle.
Yes.
Maybe she was a bit
But
intimidated by the way I was.
yes,
like,
your acting was too good.
maybe she felt intimidated because
No, in exam,
but
the candidate, the actor will be a lot more anxious and feeling guilty and a lot more intruding than you were. Yes, continue, please. Give the
maybe my
feedback.
first throw, my first question made her, I mean, anxious, and then maybe the remaining also she was a bit not confident and all. But she did try to like answer all my questions. Yes.
Yes.
And when I said about the change of the consultant or surgeon,
Yes. Her
like
answer
she
was
said,
wrong.
yeah.
Yes. Never promise anything. Never out of the text, out of the context. Never say that, okay, you'll see if you can change the consultant. Once you said he's the excellent one, then okay, full stop. End the conversation on it. And in conversation, always remember you're the surgeon. If it's a patient or if it's a patient's relative, whoever that is, they should be listening to you. Your voice should have that command in it. So always bring the command in your voice. Dr. Abhishek is unmuted. Yes.
Yeah.
But maybe we can,
It was-
Dr.
it was
Abhishek,
great.
just a second. Maybe we can ask Dr. Kama if he has to say anything more first.
Yeah, sure,
Yeah,
sure,
maybe,
sure.
maybe, I mean, she has the, I mean, information,
Yes.
but with practice, I think she will improve.
Definitely,
She
yes.
will be confident.
Yes.
Yeah.
Thank
Yeah,
you.
Dr. Funas, it was really good from your side. So,
Yes.
like I think you have started just a few days back about your preparation, but you tried your level best at that point, like to convince the mom about the operation and everything. Here are some like kind of tips about this type of like broken down heart patient, this type of angry or any type of angry patient. So the patient was kind of intimidating. So whenever you start something like that, at first ask them about how far they know about their child, something like that. So whenever the patient, the person is saying something like from his or her knowledge, so you have an idea about like how far the patient actually know. Just spread some convincing words or reassuring words. So I'm here to tell you about your child and tell you everything about your child, and I'm so sorry that you haven't been informed earlier. So could you please tell me like how far do you know about your child? So where the person is saying, so you don't interrupt, and after that, okay, whenever she asks you something, you just say, I that's really I really appreciate your question here. So far your girl is doing better, and your girl came to us something like this, so now your girl is in no pain. So it was like you were saying everything, but you were a little bit nervous in this situation, as the person was that much intimidating. So nervous, you just listen, you just make the eye contact with the person, and just nod your heads whenever she is saying something, and okay, answer accordingly about their query and everything. So whenever the patient was saying, okay, no, I will not do the procedure with that. So you could just say, okay, Mr. Ladd is one of the best have in our hospital. So definitely we'll make sure that your child get the best. So these type of reassuring words you just practice for every station whenever there is some kind of anxious patient or angry patient. And after that, whenever you say something like this, you will face in the exam, okay, the person is just cooled after your words, something like that. So these actually happen. So in our exam also, that the angry thing like that, we could not like promise him anything, but whenever we said something, definitely we'll take care of you, we will ensure the best care for you in the future. The patient got chilled, something like that. So these are some kind of advice like from my side. I definitely will do better in the upcoming days. Just don't be nervous. This type of things can happen. Like in case of the confusion station, the patient was like sleeping in the station. This type of patient actually come in the exam. So don't get nervous. You just ask, you just do your part and be confident about your counseling. That's all from my side about this type of anxious or angry patient station. Thank you so much.
Thank you. Thank you.
Yeah.
And here is your question. Right, so if you have read and understood considering a procedural scale station, kindly begin. Kindly begin. Has he got disconnected?